Hi, everybody. Welcome to the lecture on manual therapy and therapeutic exercise in the treatment of the shoulder. So, we're going to talk about some interventions that you can apply with your patients. What we're going to discuss is not all inclusive. I'm simply presenting you with some options for interventions with your patients. There are many more exercises not in this presentation than there are in this presentation. So we're going to talk about interventions for the glenohumeral joint, the scapulothoracic joint, musculature, specifically exercises for weakness and timing. Many dysfunctions at the shoulder are caused by issues in one of these areas, whether it's impingement, rotator cuff, tendonitis or tendinosis, instability, or labral tear. So knowing at a basic level will help you get a feel for how to address these problems. We'll also talk about some issues related to hypomobility or decreased flexibility as well. I would highly recommend and insist that you refer to the Kisner and Colby book to supplement this integrity for exercise. We're going to discuss interventions on campus as well. The article entitled Current Concepts in the Scientific and Clinical Rationale Behind Exercises for Glenohumeral and Scapulothoracic Musculature, that is posted in the course content folder, is a really nice summary of all the evidence for the use of different exercises and how one might be better than the other to strengthen a particular muscle. Read it. There's a nice summary table at the end. And then finally, I'd like to thank and acknowledge Dr. Allison Zager for expertise and assistance with this lecture. So I've divided the interventions to those primarily focusing on the rotator cuff, and those focus on the scapula and its surrounding musculature. Will include manual therapy under scapular interventions, even though much of it is for both. So first, rotator cuff interventions for weakness and timing problems. Let's talk about therapeutic exercise first. So when we talk about therapeutic exercise, we need to think about a few things. The emphasis in the early stages of rehab is on scapular control and humeral head stabilization, as well as restoring the coordinated action of the force couples of both the glenohumeral and scapulothoracic joints. Establishing strength, balance, and control of these force couples will regain humeral head control during dynamic movement. Keep in mind, though, that it is essential to decrease pain and restore movement both before and in conjunction with these exercises. So here's a few things we want to think about when we're getting ready to perform our interventions. What muscles do we want to activate and why? Are we increasing strength? Are we causing the muscle to hypertrophy? Which specific muscles are involved in normalizing glenohumeral mobility and strength and normal scapular function? And also, which muscles do we want to inhibit? Okay, so I want you also, in addition to producing muscle hypertrophy, making the muscle bigger by strengthening, we also help the muscle neuromuscular in a neuromuscular sense. Okay, so it's still even though the muscle might not be growing or increasing in size, there's still increased force production from strengthening. There's still improvement of muscle activation and timing. So actually, a lot of exercise programs that we do in the clinic use very light or moderate resistance below that threshold that would generate muscular hypertrophy. Okay, so you're still getting effects even though you're not doing heavy weight. And for a lot of muscles, you don't need to be using heavy weights. Okay, so let's look at this slide. There's a couple of studies that have shown best rotator cuff exercises, best scapular exercises. So in this first one by Townsend et al. 1991, those are all good exercises for various rotator cuff muscles. Although I don't like scaption with thumbs down because that puts the patient in internal rotation. We always do that would be the empty can exercise. We usually do full can exercise. Horizontal abduction with external rotation, the press up. This is a really good article by Reinhold for strengthening the external rotators. You can see a couple of exercises: side lying external rotation, extension and prone horizontal abduction with external rotation, and prone 90-90 external rotation. For the scapula exercises, again, scaption, rowing, push-ups with the plus, press-ups, to activate the lower trap. We see in the next study external rotation while we are retracting the scapula. So here's a couple of pictures. This is scaption. This is a patient doing scaption. Look at that, thumb up, full can, okay? Just going up to the horizontal. We do not want them going above 90, okay? But we want to make sure that they can do this with a good scapulohumeral rhythm before we do it elbows extended. We might want to start with the elbows flexed if they're very weak or if they had just had surgery or something like that, okay? Another good exercise, which is also for the lower trap, prone horizontal abduction at 100 degrees. We want to be careful also because if somebody is not able to stabilize with their lower trap enough, they're going to impinge because that shoulder is going to elevate and tip forward, and they're going to have problems. So we want to make sure we probably don't want to do this early on in rehab. Okay, something else, we talked about scaption, and we saw the patient in the picture before doing kind of a full can exercise. So if somebody can't do that, here's another progression called the lawn chair progression that we can have them do. So first we can have them do it in supine on the table, and we can gradually put them more upright by using some kind of a wedge or pillows or something like that until we can get them so that they're able to do it against gravity, okay? So it's just another way to progress somebody without putting too much stress on the shoulder and having them do scaption from supine all the way up to sitting, okay? Okay, also rotator cuff, some exercises for the rotator cuff. For the infraspinatus and teres minor, they're external rotators, external rotation with TheraBand, side-lying external rotation, bilateral scapular retraction with external rotation, prone external rotation. Just think about also when you're doing these exercises, think about that bringing your arm away from your side. The more that you do that, you decrease the activity in the infraspinatus and you increase the activity in the supraspinatus and deltoid. So think about what you want to do, what you're using it for, what type of pathology the patient has. If they do have supraspinatus tendonitis, if they have had a repair of the supraspinatus, then you might not want to work at first in so much abduction. You might want to keep them closer by their side. Okay, and this is them doing with TheraBand. Oh, I'm sorry, I forgot to say. When you're doing it standing or side-lying external rotation, it's been shown that you're going to increase the muscle activity in the infraspinatus by about 10% by placing the shoulder in 20 to 30 degrees of abduction. I think we talked about before it prevents that wringing out of the supraspinatus tendon because it's not being pulled right over the head of the humerus. It's also been shown that there's enhanced blood flow in slight abduction versus the arm at the side, and also the isometric adduction contraction of keeping your elbow, holding that towel in, produces a significant opening or an increase in the subacromial space. Okay, so that's kind of what this picture is showing here. All right, again, same thing. We talked about putting a towel in there. They're side-lying, so that optimizes the blood that's getting to the rotator cuff, and it's also increasing the recruitment of the infraspinatus. Okay, and here we talked about that bilateral external rotation. We have the patient retract. They're squeezing their shoulder blades together, and they're performing external rotation with both hands using that TheraBand you can see here. Great exercise for the external rotators. Okay. Okay. The other exercise that we talked about was prone external rotation. Of course, if the patient can't get to 90 degrees, this is going to be tough to do. Okay. But you see her here. You see the nice towel holding her in neutral horizontal abduction, and the patient just externally rotates. And again, fine. You start out with the weight of the arm, and you progress slowly. Okay, let's talk a little bit about the internal rotators, the subscapularis. It provides glenohumeral compression. It's responsible for internal rotation and some anterior stability. It creates the greatest torque at 0 degrees of abduction with the arm by the side. Okay. To strengthen, of course, glenohumeral internal rotation. Push up with the plus, dynamic hug exercise, and the diagonal exercise. And so let's go over those. This is a diagonal exercise. Okay, he's starting at 90-90, and then he's bringing his arm forward like he's swinging a tennis racket, down and across. Okay, with internal rotation and horizontal adduction. Not exactly how you swing a tennis racket, but similar. Okay. All right, neuromuscular dynamic stabilization. All right, so these are all exercises to do kind of using our PNF. These are a little bit more advanced type exercises. So we're putting the patient either they're going through the motion or else they're holding at end range, and we're giving them manual resistance. So you can see here, this patient is using TheraBand. He's externally rotating, and the therapist is giving him resistance, maybe at that spot, maybe as he goes, maybe as he externally rotates out, or just at one position. Look at her. She's at 90, 90, performing external rotation with the TheraBand, and he's doing the same thing at the top of the motion at 90-90. He's giving her resistance actually on both sides of her forearm, which is great to get those dynamic stabilizers firing at all different positions. Okay. Some more ideas for dynamic stabilization. Look at this guy. He's seated on a ball. So it's making it even harder as opposed to standing. Again, he's got one leg up, so his base of support is unstable. He's on one leg. He's even more unstable. He's sitting up straight, and the therapist is giving him resistance he's pulling against the TheraBand or the tubing, and the therapist is also giving him resistance. So let's look at this in real time, and you can see what the therapist is doing. Okay, so the therapist is giving him resistance as he goes into external rotation right now, and then he's holding it at the end range, and the therapist is giving him, and now he's doing eccentric. Okay, so we got kind of all three different motions that time. I'll play it once more for you. Here we go. Okay, so he's got the TheraBand and the patient and the therapist resistance. Now he's at end range, and the therapist is giving him dynamic stabilization right there, and then he's doing eccentrics. Okay, tough workout. Great exercises. Okay, a little bit more neuromuscular stabilization here. The patient looks like they're probably in a little bit of abduction, maybe like 30-45 degrees of abduction, and the patient is doing some rhythmic stabilization on either side of the arm into internal and external rotation. The therapist is cueing the patient to hold it there. You can start off with the eyes open and progress to eyes closed, and that's much tougher. The patient doesn't know when it's coming. Okay, they're doing the same thing here, but the arm is at 90 degrees of flexion, and you can just give resistance at all different points. Of course, it's going to be easier to hold. Oops, sorry about that. Let's go back. So it's going to be easier to hold if you're giving resistance down here. The further up the arm you go, the tougher it's going to be for the patient to hold, because you're going to produce more torque and the patient is going to have to work harder since it's further away from the axis of motion. Okay, so here again, here's another video of a therapist working on dynamic stabilization. Look at the patient. He's holding a tennis ball. It looks like a tennis ball against the wall. So he's holding it there, and then the therapist is going to give him resistance on the arm. So let's watch that. Look at that. All up and down the arm. He's got to hold it there, back and forth. They don't know what's happening. He's changing the rhythm. He's changing where he's giving him resistance. The person doesn't know. Tough exercise, but good dynamic stabilization, okay? All right, okay, again, same principle. We'll talk about these, and let's start with this guy first, okay? Again, that's a little bit more of that external rotation type exercise, okay? The therapist was giving him resistance as he was going into external rotation. And in this one, so he's at 90-90. We're just doing it at a different angle, okay? Same principle. There he is back at end range, okay? And there we go, the eccentrics. So he's basically doing the same three things, just the patient is at a different angle. So here he's inside, he's in with the arm abducted to 0, and here's with the arm abducted to 90, okay? Which do you think is tougher, huh? That one's much tougher, okay? This is a really tough exercise. Okay, let's go on, but good. All right, let's talk about scapular interventions. So somebody, say, has abnormal scapular kinematics. Their scapula is not moving, okay? What contributes to abnormal scapular kinematics? Soft tissue-wise, the pec minor, okay? If the pec minor is really tight, okay, it's going to resist normal upward rotation and posterior tilt and external rotation. That should happen, okay? If the shoulder is tight posteriorly, it's going to pull the scapula out laterally, okay? Particularly during humeral internal rotation. Something else that we want to be aware of is thoracic posture. That increased thoracic kyphosis decreases the subacromial space, and it decreases the amount that scapulothoracic and glenohumeral musculature are able to fire. Okay, so what can we do for pec minor tightness, posterior shoulder tightness, and so forth? Okay, so for pec minor tightness, of course, we're going to do stretching for posterior shoulder tightness, joint mobilizations, horizontal adduction stretch or the sleeper stretch, and of course, for thoracic posture, we talked about thoracic joint mobilizations, postural exercises, and having the chest up during therapeutic exercise. Okay, so pec minor stretching, we can do the corner stretch, we could do therapist stretching. We could actually stretch out the pec minor, and I think that's on the next slide. But scapular retraction at 30 degrees of flexion will make the greatest change in the pec minor length. And here are 4 different positions that you can do. Just be aware that some of your patients may not be able to get into some of these positions. So you might have to work with them and find alternate positions for them. Okay, therapist-directed positions. Everybody's seen it differently. Here's one stretch, pushing down on the shoulder in line with the fibers of the pec minor. Here's another one, right over the coracoid, just pushing down. Okay, I've also seen it done in sitting, where you're pushing on the inferior angle of the scapula from the back to help with posterior tilt, and then you're pushing from the front with the other hand, and that's stretching the pec minor. Okay. For posterior shoulder tightness, okay, cross body stretch. Right here, the therapist is putting their hand on the scapula, all right, to stabilize it, and then they're stretching across the body. Some people might not, some of those impingement patients might not be able to tolerate 90 degrees of flexion, so you can start them down here a little bit. You don't have to go quite up all the way into 90 degrees if they can't tolerate it, okay? As far as the sleeper stretch, okay, there's controversy in that it used to be taught that it was done just with the arm out at 90 degrees at the 90-90 position, and you had the patient push down. Now, and that really kind of puts the patient right back in that impingement position. So now, like this guy is doing it, he is in more of the plane of the scapula. So he's putting the arm in the plane of the scapula simply by maybe rolling over a little bit more, okay? And he's putting the arm in a little bit more horizontal adduction. He's not all the way, he's not horizontally abducted so much, and then he's doing it that way. And then here we go, and the therapist is assisting him by kind of rolling him back to get more of a stretch in the posterior shoulder, kind of giving him a little help there. Okay, all right, so how do we know if somebody's tight? Here's one way. This is from an article. Okay, they lie on their non-tested side. The arm is brought up into 90 degrees, and we're measuring with an inclinometer up here how far down they can go into horizontal adduction. Okay, pretty straightforward. Okay, make sure you stabilize the scapula here so it's not moving also. Okay, and that's going to quantify it, and that's going to make it a little more valid, or much more valid, because the scapula is not moving. Okay, and you take that angle, and then you can use that objectively to compare treatment by treatment. Posterior glides, we know how to do that. Okay, we can do them starting in the loose pack position. Okay, do our posterior mobilization, and then we can progress at the end range of flexion. She's kind of pushing down like this. Okay, we can also do a lateral humeral distraction while we do our posterior mobilization. So she's pushing down and she's laterally distracting. You can just push down also. That's something definitely valid to do. You put the patient in 90 degrees of flexion and just push straight down through the humerus and mobilize them that way to stretch out that posterior capsule. You would think when we talked about glides and slides and rolls that if you do a posterior glide, that's going to help internal rotation. But a lot of times we'll do it for external rotation just because it does help stretch out that posterior capsule. Okay, so we're not really doing it for the joint per se, but we're using it to stretch out the posterior capsule or the soft tissue. Okay, so these mobilizations can sometimes be used work more than one way. They might affect more structures than actually the joint surfaces. And we know all about these. We can help improve posture by doing our joint mobilizations, our manipulations, and here you see them doing a mid-thoracic thrust as in addition to prone PAs. All our postural exercises, chest up. We want to make sure our patient is always performing all of these exercises with our chest ups. Okay, that way we know that we will achieve at least a modicum of scapular retraction. We will get those scapula so scapula is back, so we can increase the subacromial space, and so that the supraspinatus will fire like it's supposed to and like we want it to. Other manual treatment, we can use our soft tissue mobilization. Sometimes patients are lacking in external rotation or lacking elevation due to a tight teres major, a tight subscapularis, tight lats, especially for those athletes or for those patients with a lot of thoracic kyphosis, okay, a lot of forward shoulders. It's good to get in there and do some soft tissue work there, do some trigger point release possibly, as well as cross friction to the supraspinatus, which may help with healing as well. Okay, all our joint mobilizations, posterior, inferior, all our scapula glides. If we want to increase range of motion, which is usually the case, we perform grade 3 and 4 at or toward the end ranges of range of motion. Okay, so we're bringing the arm out away, we're bringing them back towards the end range of abduction or flexion, whatever it may be. Okay, we can also do, we can also have the patient perform movement as we mobilize them, bring them into posterior glide and have them externally rotate. Sometimes that will help, or internally rotate if that's limited. Okay, so there are lots of different combinations and interventions and things that you can do. Okay, let's talk about scapular muscle weakness or timing problems. Okay, why might someone have abnormal scapular kinematics or an altered scapulohumeral rhythm? Okay, we know that the activation of these scapular muscles has to be spot on for someone to have normal elevation. If they're not, if the force couple firing is altered, that can cause all types of problems. So, for example, the force couple between the upper trap and the serratus, along with the middle and lower trap. So we see delayed activation of the middle and lower trap in subjects with shoulder impingement syndromes. There's decreased serratus and increased upper trap activity. So we really want to make sure that those scapular muscles fire early and on time, so they can kind of set the scapula, so they can cause that scapula to be a strong base when those glenohumeral movements occur. Okay. Okay, so weakness and timing problems, we need to strengthen those scapular stabilizers to prevent winging, promote scapular elevation, external rotation, and posterior tilt. Again, we need to make sure that scapula is in the correct position, and these are the 3 muscles which we need to focus on. Okay, the serratus, it works with the pec minor to protract the scapula and with the upper and lower trap to upwardly rotate the scapula. So it contributes to arm elevation. It does all these things. It also stabilizes the medial border inferior angle, preventing winging and anterior tilt. Some of these exercises, PNF, D1 and D2, supine punches, push-ups with a plus, dynamic hugs, and wall slides. And here we see the dynamic hug. Okay, you have a thera tubing. Your elbows are about bent at 45 degrees, abducted for the shoulder about 60 degrees, internally rotated, and then you're just doing a full big hugging, like you're hugging your favorite person, your wife or your grandma or your kids. Okay, think of them that they're really fat, but you're still hugging them. Okay, and still you get the full shoulder protraction. Okay, punches. This is a little more advanced. Serratus anterior punch at 120 degrees. You begin by your side and you extend your elbows up till 120 degrees of elevation along with full protraction. So you're kind of working against gravity with this. And this is a tough exercise. See how he has a nice base of support standing on the TheraBand and punching up. The wall slide exercise, starting here and just sliding up, pushing up into the wall, and here's a lateral view. Okay, best exercises for the other muscles. Middle trap, prone row, prone horizontal abduction at 90 and at 135. Lower trap, prone rows. Again, same thing, prone horizontal abduction, standing high scapular rows, and bilateral external rotation at 0. Okay? So, prone horizontal abduction with external rotation and prone extension activate the middle and lower trap earlier than the upper trap or the posterior deltoid. Okay, so that's a really good exercise for those folks with timing problems. The way that we activate the lower trap tends to be at angles greater than 90. The activity is kind of low if we do it at less than 90 degrees of scapular abduction. We want to do it at least more than 90, making sure the patient can achieve that. Okay, and here we go. This is not a good picture. I'm not sure why it's like that, but she's doing. Looks like she's doing shoulder extension. Sorry about that, and shoulder retraction. I don't know why this is like this. Sorry. And here we go. Prone horizontal abduction with external rotation. The arm is oriented as to the firing pattern of the lower trap. It's in line, okay, at about 120 degrees. All right, so here we can see a couple of different exercises. Here's the patient doing that exercise, giving us a nice contraction at the top. He's going up a little faster, coming down slow, thumb up. Here he goes again. Oh, look at that. And now he's doing some eccentrics for the lower trap. So the therapist is helping him go up, and then he's lowering slowly. Good. Okay? Now, prone horizontal ABD with external rotation. So it comes up into horizontal abduction, externally rotates, comes down, and then lets his arm down. Okay? Really good exercise. Lower middle trap. And here's just a prone row. And again, prone rows. Look at the therapist giving him, again, so he's giving him resistance concentrically, then he's giving him resistance at the end of the motion, and then he's doing eccentrics. Okay? So he's doing kind of the same three things in all the videos that we've seen. Giving concentric, okay, range resistance. Then he's at the end range, he's doing some rhythmic stabilization at the end range, and then he's giving him eccentric. Okay, so all of that in different combinations is great work.